Hello, and welcome to the Medicaid and CHIP Payment and Access Commission's Medicaid 101 series. Today we'll be talking about disproportionate share hospitals, but first a little bit about the Medicaid and CHIP Payment and Access Commission, or MACPAC. MACPAC is a nonpartisan legislative branch agency that provides policy research and data analysis that is both fact-driven and evidence-based. We make recommendations to Congress, the Secretary of HHS, and the states on a wide array of issues affecting Medicaid and CHIP. For more information about MACPAC, please visit our website at macpac.gov. The purpose of the MACPAC 101 series is to provide educational content and highlight, where applicable, recommendations that the Commission has made previously. This Medicaid 101 presentation will focus on disproportionate share hospital, also known as DSH, allotments and payments. We've organized this presentation as follows. First, we're going to cover DSH payments, which broadly support safety net hospitals and are one of many supplemental payments that are used by states to pay hospitals. This next section is going to talk about DSH allotments. DSH allotments provide the limit for how much states can actually spend on DSH payments. The final section is going to discuss MACPAC's DSH analyses and some of the recommendations we've made in recent years. All right, so this first section is on DSH payments. DSH payments originated in statute in 1981, and under statute, these payments account for the situation of hospitals that serve a disproportionate number of low-income patients with special needs. States began to make these lump sum supplemental payments for these types of hospitals after the Boren Amendment uncoupled Medicaid payment methods from Medicare payment standards in 1981. However, these payments did not take off as a share of Medicaid spending until Congress required states to make DSH payments to hospitals that serve a high share of both Medicaid and also low-income patients in 1987. Generally, DSH payments broadly support safety net hospitals, but only certain types of safety net hospitals can actually receive a DSH payment. To qualify for a DSH payment, 1% of a hospital's inpatients must be Medicaid, and there must be at least 2 obstetricians with staff privileges that treat Medicaid beneficiaries. However, rural and children's hospitals are also eligible for DSH payments. States are also statutorily required to make DSH payments to so-called deemed DSH hospitals. These hospitals must have a high share of Medicaid patients compared to other Medicaid hospitals within the state, or see a large percentage of low-income individuals. However, even though states must pay these hospitals, the payment amounts can actually be pretty nominal, and sometimes are as little as $1. Hospitals receive DSH as a lump sum payment that covers uncompensated care costs for a set period of time. Each hospital has a limit to DSH payments, which equals total uncompensated care costs. So the DSH limit is the sum of Medicaid shortfall, which is the difference of total costs incurred and payments received for services to Medicaid eligible patients, and unpaid costs of care for uninsured patients. So this includes things like charity care and bad debt for individuals without health insurance. However, most hospitals do not get paid up to the DSH limit. We're also going to be talking quite extensively today about DSH targeting. So by DSH targeting, what we mean is prioritizing a hospital or a group of hospitals over other hospitals. Another way of thinking about this is who's getting that first DSH dollar versus who's getting that last DSH dollar. Because of the broad DSH qualification criteria, states have flexibility to send DSH payments to virtually any hospital within a state and have broad discretion over their targeting policies. For example, some states target DSH payments to publicly owned hospitals, some to rural hospitals, while others might target using more complex rules based on the unique health system needs within each state. Many states also target DSH payments to deemed DSH hospitals, while some do not. Deemed DSH hospitals do make up under 1/3 of all DSH hospitals, but account for 2/3 of all DSH payments. And states vary quite extensively in terms of how much DSH goes to deemed DSH hospitals. This table shows how DSH payments are distributed. Overall, we estimate that 42% of hospitals in the US received about $17 billion in DSH payments in 2018. As you can see, most payments do go to short-term acute care facilities, but many payments are also sent to other hospital types, such as psychiatric or children's hospitals. Also, as you can see, most DSH payments do go to these deemed DSH hospitals, which again are high-volume Medicaid or high-volume uninsured facilities. In 2018, this equated to about $10 billion in DSH payments. The extent to which DSH dollars goes to specific hospitals versus all hospitals within a state varies extensively on each state's targeting policy. This chart summarizes the extent to which payments are targeted. States on the left target DSH to a small percentage of hospitals, while states on the right, like Kentucky, New York, or New Hampshire, don't have a clear targeting policy, since virtually all hospitals within the state will receive some kind of a DSH payment. States on the top, they primarily target DSH payments to deemed DSH hospitals. These are states like Maine, Illinois, and Iowa, who target their DSH to a small percentage of hospitals. Almost all of them are deemed. It should also be noted that DSH payments are only one type of supplemental payment that a hospital may receive. There's also what are called upper payment limit or UPL payments, uncompensated care pool payments, and others. As a whole, supplemental payments make up around a quarter of all payments to hospitals, while DSH makes up a third of all the supplemental payments. For more on base and supplemental payments, please refer to our 101 presentation on payment and financing for hospitals within Medicaid. Okay, now we're going to start talking about DSH allotments. Due to legislation on DSH payments in the 80s and 90s, DSH spending grew rapidly from $1 billion to $18 billion by 1992. By this point, DSH equaled around 15% of Medicaid spending, and Congress at the time was worried about the effects that this would have on the federal budget. To lower spending, Congress enacted state-specific caps on the amount of federal funds that are used for DSH. These are now known as DSH allotments, with total DSH funding being limited by the federal allotment on the one hand and then the state share on the other. These allotments also vary quite extensively by state and are based on each state's spending in 1992 instead of a clear measure of need for DSH payments within each state. This means that states that had the most DSH spending in 1992 now have the highest allotments, regardless of the state's level of uncompensated care. DSH allotments increase annually with inflation, but DSH allotments are also capped at 12% of a state's Medicaid spending. However, it should be noted that no state has been subject to this threshold since at least 2016. However, this threshold does have real-world effects, and calculating the threshold delays finalized DSH allotments by several years after the cost for uncompensated care has been incurred by the hospital. This means that states generally withhold a portion of DSH payments until the allotments are finalized so that they don't have to recoup the payments from hospitals later on. DSH allotments were also supposed to be reduced many times over the last decade. The ACA was expected to lower state levels of uncompensated care due to Medicaid expansion and the availability of insurance subsidies, and thereby decrease the need for DSH payments. The ACA scheduled a series of allotment reductions that impose greater cuts on states with low rates of the uninsured, states that do not target DSH payments as safety net hospitals, and states with large DSH allotments. These allotment reductions were supposed to begin in 2014, but they have been delayed multiple times. The most recent delay was in the 2021 budget bill, and under that legislation, Congress delayed the DSH cuts to fiscal year 2024 and scheduled them to be $8 billion per year from 2024 to 2027. This means that starting in October, DSH allotments will be reduced by approximately 58%. Also, there are no cuts scheduled for 2028 and beyond, which means that allotments will revert to their unreduced amounts. Congress has also temporarily increased allotments during economic recessions because of the interaction of the enhanced FMAP on DSH payments. During economic recessions, Congress will usually provide economic relief to states and Medicaid programs through FMAP adjustments. Because DSH allotments are based on federal amounts, total DSH funding actually ends up declining when the FMAP increases. Congress did this in different ways during both the 2009 financial crisis and then also during the COVID-19 pandemic. All right, we're now going to talk about MACPAC's DSH analyses. So in 2014, when Congress first delayed the DSH cuts by several years, They had implemented the DSH cuts from 2016 and had it last through 2024. As part of this, MACPAC would be required to report annually on the allotments and the effects that these reductions were having on hospitals. The report required MACPAC to compare allotments to various measures of need that Congress asked us to consider. These included state numbers of the uninsured, amounts and sources of hospital uncompensated care costs, and the number of hospitals with high levels of uncompensated care that also provide essential community services for vulnerable populations. Our primary finding from these reports is that allotments and their pending reductions share no meaningful relationship with the measures of need that Congress has asked us to consider. Even though these cuts were eventually postponed to start in 2024, MACPAC was still required to report annually on DSH allotments and measures of need. These reports have articulated a series of recommendations endorsed by the Commission to improve DSH policy. These include efforts to improve data transparency on all payments an individual hospital receives and data on how those payments are financed. It includes recommendations on how to better structure the pending DSH cuts should Congress proceed with those cuts. It includes recommendations around how to automatically adjust DSH allotments when the FMAP changes, so total DSH funding grows with inflation from year to year, and it avoids penalizing states with an increasing FMAP. It also includes recommendations on how to define Medicaid shortfall when determining total uncompensated care for DSH hospitals. The Commission has also weighed in previously on how to improve the targeting of DSH payments to hospitals that serve a high share of Medicaid and uninsured patients. However, the Commission has not made a specific recommendation on DSH targeting. I wanted to end the presentation with a series of publications that we have on our website. This includes a history of DSH payment policy, our various DSH allotment recommendations in 2019 and 2023, our Medicaid shortfall recommendation in 2019, and it also includes a link to our latest statutorily required DSH analysis, which occurred in 2023. That closes our presentation on Medicaid DSH payments and allotments. Thank you for listening to our 101 presentation. I hope it was informative.